Hello, kidney warriors. James here from Dadvice TV. And this is another episode of Dadvice TV Live. Now, we're going to do something really special for all of you out there. We're going to do an Ask Me Anything. But you're not going to be asking me, a kidney patient. You're going to be asking a nephrologist, a kidney expert. As a matter of fact, we are going to have an expert who wrote what I think is the best book about kidney disease. It's easy to read, easy to understand, and it tells you what you need to focus on, and more importantly, what you don't need to get worried about. Because when you're diagnosed with kidney disease and you go out there on the internet, oh my goodness, it is a world of doom and gloom and so much conflicting information and misinformation that's saying, don't eat this, don't eat that. But it's not saying when you don't eat those things. It's assuming, everyone avoid this, avoid that. Don't have a banana. Oh, no potatoes, no avocados. It'll be the end of the world. That's not what it's like. This book will help you see the truth so that you're not afraid of what you're going to be eating. You'll know what to focus on, what to do. And that book is called Learn the Facts About Kidney Disease. And it is by the one, the only, Dr. Stephen Rosansky, who comes here once a month. We do a great live show talking about a topic, and he usually sets aside about 15 minutes or so at the end of each live broadcast to answer your questions. But today, we've got him here for the full hour to answer your questions. So I want you guys to go ahead and start putting your questions in the comments, just like we got one here from Karen. Hey, Karen, we're going to get to your question in just a second. Let me bring on Dr. Rosansky. In case any of you are new, he's going to give a quick introduction about himself so you know why the things that he says are the things you need to listen to, and they're based on science and facts, not what we like to call woo-woo or made-up stuff. So let's go ahead and bring him on. Hey there, welcome, Dr. Rosansky.
Hey, James. Yeah, I want to just tell your folks out there that I messed up. I was supposed to be on, what was it, Monday?
Yeah,
And
Monday.
I got my schedules all twisted. And so I asked James if he wanted me to come on tonight. So I hope some of you that had questions for me on Monday know that I'm on tonight. And if we don't get enough questions, James, I'm going to ask you to sing.
Hey, I have no problem singing. I'm not great at it, but I do it. I make up for quality with volume.
We'll see if we need the entertainment. Yeah, so I'm a retired kidney specialist. I took care of kidney patients and internal medicine patients for over 40 years. I also am what you call an academic as well as a clinical nephrologist. I've got about 100 publications that you can look up, and a lot of my work has to do with progression of kidney disease as well as the issue of when to start dialysis. And the latter question is one that got me to write the book that James mentioned, because people were and still are starting dialysis way too early, unnecessarily. But I've got some good news, and I'll tell you before we start answering questions. And I'm currently working on a book on longevity, and hopefully I'll be able to discuss this things that you folks might be interested in on James' show. And yeah, I'm oriented towards something called clinical epidemiology, which are these are the folks that try to get good studies, look at the quality of studies, and try to figure out what really means something for the patients, as opposed to, as James called it, what is just woo-woo and really will have no benefit. But I will start out with a couple of things which I'm really happy about. Now, on your show, James, I have talked many times about something that you've experienced, and my guess is a lot of people that have watched your show have also experienced. It's called acute renal failure, meaning that your kidneys, your kidney function goes down temporarily. And a real common situation is one where your kidney function goes down, and I'll give you some of the reasons why it could happen. Temporarily, get in the hospital, and they put you on a kidney machine because they can. And because there is an orientation to treat. Treat. There's very little emphasis on, just observation or doing a detailed analysis of benefit versus risk. You got something, you got a machine, you got a patient, that kidney numbers look bad, put them on the machine. And of course, there's a financial incentive, huge financial incentive. Which, by the way, when you dialyze a patient in the hospital, it is probably a return for the people doing it about double what they would get if you are on a chronic outpatient situation. Just a point of information. So, and I've told you folks many times that, like James, you may come in the hospital because what often happens is you're sick, you've got the flu, you've got some other infection, you get dehydrated, in the summertime, you're not keeping up with your water intake, you're taking some of the medicines that can get your kidneys messed up, like Motrin, the NSAID NSAID medicines, or you somehow overtreated yourself with your blood pressure medicine, you got your blood pressure down to 80s, or you come in the hospital because your heart's bad and your kidneys don't like the fact that they're not getting enough blood because your heart's weak. It's a temporary, in a lot of cases, a decline of kidney function. And they finally came out with a position from the kidney docs of the U.S. They're talking about what do we do about those people. And I've been talking about this for a decade, well, at least for 10 years, probably 15 years. And I've actually was going to do a research project with an Egyptian friend of mine, nephrologist, who had data on what happens to people that, like James, go in the hospital. They had some CKD. Maybe they were 3B. Maybe they were somewhere in the neighborhood of 30 to 45 GFR. Go in the hospital, they're 10 to 15 GFR or whatever, and they get on dialysis. And what happens to these folks? So there are ways to follow your kidney function to see if it goes back to where you started. But most doctors don't do it. So this article is emphasizing, hey, you guys need to do it, and girls need to do that. And you need to not be aggressive when you put someone on the kidney machine and try to pull off too much fluid, which is a common situation. And if you do that, you're going to mess their kidneys up worse and they won't recover. So there are ways to handle. First of all, try not to dialyze somebody unless they absolutely have to, even if they have an AKI, a decline that's new. But you want to try not to aggressively dialyze them, keep their blood pressure up, and then see if their kidneys recover. And now they finally come around to say, hey, that's what you need to do. So that's one thing that really put a smile on my face. The American Society of Nephrology is finally coming across to say, hey, we need to know that people are out there that are being dialyzed that may have recovery of kidney function, and we need to treat them differently. We need to look for it. So hooray for that. The second thing, James, is there's another. These I'm talking about just coming out in the last month on my kidney journals. I keep up to date with the major kidney journals. They talk about something that you and Jen and I've talk about repeatedly: plant-based protein diets. Well, there are way too many people who have been pushing low protein diets or other weird diets. And this article basically quotes something that I've discussed on your show, James, that the one randomized controlled trial, that's the gold standard, right, What does that mean? Randomized control means you take people who volunteer for the study and you randomly put them either on the treatment or placebo. And in the only study that was NIH funded, a large study, people that were on very low protein died. They died. They had a much higher mortality. And we know that. And we know that low protein diets, especially in the older population, will make your muscles weaker, will make you more prone to falls, will make you more prone to get hip fractures and stuff like that, and die. I mean, it's real. So the people and the books and the folks that are selling you very low protein keto supplements because you're not getting enough protein, they got to give you the keto amino acid derivatives to get your essential amino acids, to be able to keep you from getting severely malnourished. All that's a waste of your time and money. Please don't do it. And you can be on a low protein, you can be on a relatively low protein diet, which is the only thing that's recommended. And that's somewhere around 80 to 100 grams of protein on average, not like this 20 to 30 gram crazy thing. And, you're probably much better off. And you can be on plant-based diet, which is great for your heart, great for your longevity. And, the potassium issue is something to be aware of, but as long as you've got a decent provider, they'll keep an eye on your potassium, and you've got a decent dietitian. So those are things that came out just in the last couple of weeks that I'm really excited about, and I'm happy to report that stuff that we've been talking about is now being discussed in the mainstream media.
Well, I'm glad to hear about the AKI treating that differently. If considering it, because that was the challenge I had, was they wanted to put me on dialysis, and as I started reading and learning about it from the ICU, so I didn't have a lot of time. I couldn't talk to a lot of people, but I felt no, and internally I thought, no, I've got food sickness, food poisoning. And I know that ended up being wrong, but I felt like, give me a chance. Don't hook me up for this. Because when I asked him, I said, well, how long, do you just hook it up for a few hours or what? And then I go home and the doctor told me, no, this is forever. And you'll eventually need to get a kidney transplant. Um, but I'm glad that I didn't get hooked up to that machine, because would they have watched me to see if I could have gotten off? Or would I, now almost 7 years later, still be on dialysis, which doesn't have a good outcome long term? It's tough on the heart. So I'm glad they at least have guidelines now to hopefully catch more of those acute kidney incidents, to give the person a chance to see if they can get better. At least, I'm happy to not be on dialysis. My kidneys aren't great, but they're good enough right now. I'm still working. I feel great. Remember, outside of my labs, you couldn't tell I have kidney problems right now. There's not a symptom.
And let me reiterate something that we might have said a few times. You don't need to be on a machine because your GFR number is any particular number, whether it's 15 when a lot of docs put you on, which is crazy, even whether it's 10, where they say, oh, it's 10, you got to go on. Those numbers 10 to 15 are what we call early in the literature and in my work. Now, if you go below 10, I need to tell you what's happening around the world in places in Asia, Japan and Taiwan and mainland China. They rarely will start people, at least that's been the case, uh, above five. So 5 eGFR. So in this country, the vast majority are starting in the 10 plus range. And your kidneys are going to do a lot better for you, and this has been shown over and over again, than any machine or any fancy machine that they can put you on. So your own kidney function is going to be better than any kidney machine. So, and you just need a minimal amount of your own kidney function to get by, as long as you're making enough urine that your lungs don't fill up with fluid, and as long as you're passing the potassium, that you don't get a high potassium, and as long as you're taking the drugs that will get your blood count up, and so you're not severely anemic, you could feel pretty darn good with very low kidney function. And the best thing, especially for you younger folks out there, is to get on the transplant list as early as you can. And I'm not one of these folks that's in favor of what they call preemptive transplant. In other words, there's a lot of people, and this is a controversial area, and I'm not a transplant expert, but there's a lot of centers that say, we want to put you on and get you started with your transplant at 15 GFR. I see no rush. I would say, for the benefit of your donor of the kidney, hopefully you have a family member or even a friend that's willing to donate a kidney, no rush for that either. And certainly no rush to get on dialysis unless there's a reason. You got to ask your doctor, hey doc, why do I need to go on? Can you treat whatever my symptoms are medically and delay the start of dialysis? Because it ain't any fun, folks. I could tell you from dealing with hundreds of dialysis patients, it's no fun. I mean, we try to keep the mood up in my dialysis unit. I had wonderful staff. We try to laugh, but it's not fun. And you don't want to do it unless you absolutely have to. So,
Ready for the questions?
Yeah, we could start with a couple questions. Yeah.
All right, let's start with the very first that came in, Karen. All right, she's 3B. Her eGFR is 38, so she's right on that border. Wait, that's not 3B. Oh, yeah, that is 3B. I almost said 3A. She's 3B, no protein in the urine. Great. Age 65. Should she be following a renal diet? So what's your diet advice for Karen?
James, what is a renal diet?
So that's a great question. a, a renal diet is very broad. It would be a diet specific for someone with kidney issues, but your diet, in my recommendation is, it should be tailored based on your labs and where you're at. If you're having problems with phosphorus, the diet would be customized to be lower in phosphorus. It's a heart healthy, plant based or plant rich diet.
James, I will not at all contradict Jen, who I'm sure does a great job. But I am not sure that there is such a thing, okay? With all respect to renal dietitians. Now, when you're on dialysis, it's a whole nother story.
Yeah.
When you have minimal kidney function, it gets to be a whole nother story. Because then you got to restrict your fluids. You probably have to restrict your phosphorus. You probably have to restrict your potassium. But at what point that occurs is probably very late, okay? For the extreme, vast, 90+% of the people that watch your show, as long as they follow what we talked about earlier, a plant-based diet, relatively low in protein, which is 0.8 grams per kilo, roughly 0.4 grams per pound of protein, you're doing fine. And that's good. And the reason why you want to be on the Mediterranean diet, which is another great diet, that to me has been shown to have the most benefit for your longevity, for your major risk for anyone with CKD, which is what, James? We've talked about this ad nauseum.
Heart disease.
Give me the big word.
Arthrosclerosis. Did I get it right?
That's one. Hardening of the arteries for the lay people, or atherosclerotic cardiovascular disease. So in other words, atherosclerosis, hardening of the arteries that leads to cardiovascular, heart disease. but cardiovascular is heart and blood vessel disease. So you're on this plant-based diet, the Mediterranean diet, which is high in fruits, nuts, legumes, omega-3 fatty acids, the fatty fish, the salmon, the sardines. Go for that Mediterranean diet, because as a kidney patient, when you have a abnormal GFR, like the question was asked, 38, your main job in life is to keep from getting a heart attack or a stroke or blood vessel disease. It's possible, but not likely, that you're ever going to face a dialysis question. Now, at your age, and the age was
65.
65, okay. So now we talked about this several months ago. A lot of labs have stopped reporting the number if it's over 60. And because the actual expected kidney function number, what's normal, is dependent on your age. Now, you're in the 60-ish age range, a less than 60 is kidney disease. So that's considered kidney disease. And this person, and as James was trying to figure, and don't get confused, someone just made up these windows. 30 to 60 is 3, CKD 3. 30 to 45 is what this person has, or is it 38? Okay.
Yeah, 38.
Yeah, right. Yeah. Okay. 38 should be between 30 and 45, which now they call it 3B. Okay. And the reason why they did that is because when you get up to the higher range of 45 to 60, if you're in the age group, let's say over 70, that may be normal for you, and you do not have a higher risk of getting atherosclerotic cardiovascular disease, heart attacks, and strokes at that level of kidney function. Now, for the person who asked the question, you are at that higher risk of the hardening of the arteries related problems. So you want to be on a plant-based diet. You want to get exercise every day if you can. You want to get your LDL cholesterol below 60 if you can. Those are the main things that you need to do to decrease your risk of having a heart attack or a stroke. And that's your main job. Let your doctor follow your urine protein. The fact that you don't have much or any is a good prognostic indicator, meaning that your likelihood of progression is not very high. But you got to be monitored, I would say, once or twice a year. Urine protein. But again, get with the program in terms of lifestyle. No smoking, get your LDL down to 60 or less, get your blood pressure to goal, 120 on the top number if you can get it there, using an ACE or an ARB for your blood pressure, which are the best drugs, and plant-based diet. That's my advice.
Very good. Now, can the LDR, this is a question for me. My LDL was pretty low. It rated as low because it came in at 38. Is that too low?
No. The latest thing, James, is that if you're a high-risk patient, now, high-risk patient, if you had a abnormal GFR and high protein, that's the highest risk. Okay, or if you're a person who already had a heart attack or a stroke, you're at real high risk. They're looking to get it below 40. That's the latest advice.
Perfect.
We were when these studies first came out, and these drugs have been around for decades. They were looking at, we were happy if you were below 120. Can you believe it? Now we've got all the way down to below 40 in some cases. So you're good. You're good. And the HDL, that's in my book too. I discussed that a lot. And there are doctors that are not with the program. HDL has not been, if there are drugs to raise the HDL, so-called good cholesterol, but the studies showed that that does not benefit you. So there's no reason for you to be taking medicines to raise the good cholesterol that may have side effects. You want to get your bad cholesterol down.
All right. Let me bring in another question. Okay, Stacy said, "Hey, Dr. Rowe, she's 3A. What's your opinion on statins if your cholesterol ratio is decent but your LDL is high?" She's also looking for your opinion on semaglutide, that's the SGLT2s, for weight loss.
Yes, GLP, semaglutide is
Or
GLP-1.
GLP-1s.
Yeah. Okay, Stacy. I'll start with the GLP-1s. The GLP-1s are amazing drugs. And they are now being promoted with the SGLT2s, which is what you were referring to, because like the SGLT2s, right, they have great benefits for your heart. So now we have drugs that could slow progression of kidney decline and have a benefit for your heart. There's lots of studies on the SGLT2s and showing benefit for the heart, slowing decline of kidney function, great drugs for diabetes. If I was a diabetic, I would be all over that SGLT2, especially if you've got a history of diabetes and you've got a history of kidney disease and you've got protein in urine. Extremely important drugs to be on. The GLP-1s are now showing all kinds of benefits, but the latest benefit is that it can decrease your risk of death from atherosclerotic cardiovascular disease. Not a lot of studies, but there's a study that just came out. So if you are clinically obese, which the new definition of clinical obesity is not just a BMI over, 40 or 35, 38, but it's high BMI, but you also got a disease going on. You've got kidney disease, you've got heart disease, you've got some other problem. So where's the question? You want to put it up again? Because I'm losing track. Okay.
Yeah, hold on one sec. Here it comes. The other question was opinion on the statins.
So as we just mentioned a minute ago, my opinion on statins. If you are 3A, you may not be at risk at all. But depending on your age, now you look real young in your picture. 3A, if you're really young, could be abnormal, as we discussed a few months ago. The fact that we're not reporting in some cases values over 60 is probably wrong, because if you are, let's say, in your 40s, your normal number should be somewhere maybe around 70. So if you are like in the
got her
range,
age, 55.
Okay. So 55, you are, your CKD is minimal without proteinuria. Your likelihood of progression is low, but I think being on a statin is still a good idea. Being on a GLP-1 for weight loss, that depends on the other indications for weight loss. I would say that if you're significantly overweight and you've got other risk factors, it's something at least to consider. They're very expensive, and I'm not sure that I would do it. Okay.
Great. And she also loves your book, just as an FYI.
Okay.
Which is always great to see. All right. Let's go next to Deb and Terry. Says, good evening. I had blood work done. eGFR is a 9. And the question is pretty generic. Is there a diet plan you recommend? She doesn't have any high blood pressure, which is great. No high phosphorus.
Let's say again. No high five.
Yeah, pretty much for everyone who's asking about diet, the recommendation is like the Mediterranean, plant-based, heart healthy.
Okay, now she's GFR of 9.
Yeah, it's getting low.
Okay, and the creatinine is 466, so that's around 5 in the U.S., okay? So she's got units out. Deb and Terry are not in the U.S., and that's probably why they're not already on dialysis. In the U.K., and I've worked with people in the U.K. and in Australia and New Zealand, in a lot of my research, some of my research projects, they don't routinely start you when you're 9 or 10 like we do in the U.S. So and you don't have a great provider. I don't get that. That's kind of crazy. But look, I don't know what your age is, but the thing to do is get on the transplant list as soon as possible. If you are eligible for a kidney transplant, that would be my number one recommendation. Get on the transplant list. There is nothing in your diet that's going to affect your rate of decline of kidney function in Canada. Okay. But
Yep.
you can get on the transplant list in Canada. Canada does, and I've had, listen, one of my colleagues from Canada is the person that really inspired me to do a lot of my publications. I did a lot with him about early start of dialysis. So I know a lot about Canada, and I've been visiting professor up there.
Just turned
Very
56 yesterday. Happy birthday.
Yeah. But you need to get on the transplant list. I don't know what your institution is there, what your town is, but that's the first thing. Get on the transplant list. Because your GFR is that low, your electrolytes need to be monitored, and being on plant-based diet, there could be a potential potassium issue. So I would think about plant-based diet only with the proviso that you're getting the potassium checked. Did you say you do or do not have protein in the urine? What was the rest of the question?
Let's see. No high blood pressure, no phosphorus. All of our other levels are good. Did not mention anything about protein.
Okay. Well, that's pretty amazing. So I don't know what the etiology of your kidney disease is.
She did give
You
us a
had
little more.
liver gotcha. So you have probably cyclosporin or one of the other drugs that we use for prevent rejection that can cause some kidney toxicity. So you're already in the right place. You got a liver transplant. You want to work with the people who gave you the liver transplant to see whether, and I'm not sure whether you would be eligible also to get a kidney transplant. You say now you got protein in the urine. So, but when you're already at a 9, the various things that will slow a decline may still have some impact, but not a lot, which are the ACEs or the ARBs, the SGLT2s. So those are the drugs that you should be on. But without high blood pressure, without diabetes, I'm not sure that any of those would be appropriate. But you need to talk to your transplant people. You should be in good hands. And you're on Ozempic. Well, I guess that I don't know how that's working with the liver transplant. That's beyond my expertise. So that you're going to have to talk to your transplant people, your liver transplant people. Okay, what you got?
All right. This is pretty cool how we get to live almost talk to these people. And she's in Canada, which I love going and visiting Canada. My daughter and I and my son, we go there all the time. But my daughter and I very, very often. All right. Let's see. How often should you get your PTH level checked?
Okay, the whole issue about let me just give you background. PTH is parathyroid hormone. In addition to if you have stage 3A or even 3B, probably unnecessary to worry about it. Once you get into stage 4, let's say below 30 eGFR is when you start getting, don't look for symptoms of kidney disease until you're below 30. So a lot of people say, oh, you got CKD with GFR 50, you're going to be sick. No, you're not going to know you have it. There's virtually no symptoms except in unusual cases. But now when you get to 30 and below, things happen. You may get anemia, and you may get the bone disease of kidney patients, which relates to that hormone called parathyroid hormone. And the reason why parathyroid hormone goes up is because as your kidney function goes down, your ability to get rid of something that's called phosphorus goes down because you have less of it getting peed out. That turns your PTH level on. PTH can do some bad things to your bones. And once you get into stage 4 and 5, you want to get an occasional PTH level done. Now, the one thing we used to do is put people on these horrible phosphate binders. They're disgusting. They ruin your appetite. They're massive pills. People hate them. We're not doing that anymore. And we were also giving vitamin D early on with people with high PTHs. That's a long discussion. I do have a Dadvice on bone disease of kidney problems. Please take a listen to that because that would be more time than we have to explain. But just in general, once you get into stage 4 or 5, PTH levels make some sense. And how to address an elevated PTH level is too complicated for tonight's discussion. Look over my prior talk.
All right, very good. I'm scrolling back up to the top of the questions. Um, let's see, where was I? Is there how can you break up a kidney stone? Um, they're saying while it's passing and when it's in the kidney. So I guess for two different
Yeah.
locations.
Well, let me just first tell you the difference between me, a nephrologist, and the person that does what you're talking about, a urologist. So this is not my field, but I'll give you what I know. And there's something called lithotripsy. It's a bathtub where they shock these stones. They pass, current through it, and it puts you to sleep. And they can crush them, and you get pieces that'll come out over time of the kidney stone. There are other ways to remove it. You can go up so that there is the urethra where you pee out of. Then you go to your bladder. Then you have 2 ureters that come into your bladder. They may go up one of the ureters to get some of the stones out that way. They can crush them up that way. So those are just some ways they do it.
All right. Johanna asks, is there a medication for type 1 diabetics with CKD that will help slow the progression?
I would say the number one thing is what James says every show, and he'll tell you what they are. What are the blood pressure drugs that you say every show?
An ACE and an ARB, those are the ones that end in TAN and PRIL, and they're very common and best of all, very affordable.
Exactly. The ACEs end in PRIL. The old one is captopril, enalapril, benazepril, and the ARBs end in TAN, losartan, candesartan. Those drugs were initially studied in type 1 diabetics, and they had very good benefits to decrease the protein, which is a bad prognostic factor if you've got type 1 diabetes and significant protein in the urine. Your chances of progressing are high. So you want to be on the maximal dose of one or the other, either an ACE or an ARB. And you got to look up the maximal dose of whichever one you're on. You want to get your blood pressure to go below 120. You want to get your LDL, and I would say 40 to 50 would be a good range in a diabetic with kidney disease. Unfortunately, the great drugs for diabetes, the SGLT2 drugs, have not yet been approved for type 1 diabetes. The problem with that is that there is a certain amount of ketoacidosis, which people, if you're a type 1, you know what I'm talking about. Type 1 diabetics don't produce their own insulin, so they can get that bad phenomenon called ketoacidosis. And because there is a higher rate in some of the research, people on the SGLT2 drugs, which are remarkable drugs, they can prolong your life in terms of your cardiovascular death, slow your decline of kidney function, and treat diabetes. Keep up to date on when those drugs are going to be approved, if they will be approved for type 1 diabetics. Do you have protein in the urine? I forget. I didn't see that. Was it protein?
It did not mention that.
Okay. Well, if you have protein in the urine, you may want to take a drug that James is on. It's called an aldosterone antagonist, and I will not push the expensive one, which I don't see any benefit over the generic ones, which are spironolactone and eplerenone, and they can decrease the protein in the urine. Now I don't know what the so you want to push to the maximum the ramipril. I don't know what the top dose is. I would be on the highest dose of that, and I would not be even messing with amlodipine unless you need that to get below 120 on the top number of your systolic. But get to the do have protein, yeah.
Yep.
So you want to be on the maximum dose of the pril, which is an ACE inhibitor, and you could think about, ask your doctor about going on an aldosterone antagonist for your proteinuria, and those are the things that I would do. Okay.
Excellent. Now, there's several questions that are kind of asking the same thing, and I'm going to rephrase it so that it's easier to answer and it'll help a lot of people at once. Several people are asking, and this is something that even I was asking when I was first diagnosed. What can I do to repair my kidneys?
Right. Okay. Well, you could take the repair kidney drink, which is woo-woo, which is BS, which they should be put in jail. And there's all kinds of things that people claim that repair the kidneys. It's nonsense. It's absolute BS. People need to be arrested for the stuff they're pushing. It's nonsense. The fact of the matter is that if you have AKI, like we talked about earlier, meaning you have a GFR of, let's say, 50, and now you get something wrong. You get a flu, you get dehydrated, you get on a medicine, it goes down to 25. Well, you get off the medicine, you get fluids, you rehydrate. Hey, it's back up to 50. Oh, we cured you. It was because of the woo-woo. It was because we gave you this nonsense. I don't know. James knows some of the things they talk about.
I knew you would love answering that question.
Yeah.
And
What
it's
are some
something
of the?
that we all, when we get diagnosed, we hope there's that one pill, that one something that's $100 only that will cure and fix this.
Yeah,
And
they're gonna put you through all kinds of ridiculous sweat lodges and nonsense and make it. I mean, I don't know what people are doing. Forget that. If you have, here's the thing though. We talked about this over and over again. We define kidney disease by at least 3 months apart having two eGFRs, two kidney function measures below 60. Why? Because you may get one in my clinic at of 55. I'm sorry. Let's say 70. I'm sorry. You may come to my clinic with a GFR 50 this month. I'll have you come back in 3 months. It's going to be 70. You didn't have CKD. You weren't cured by whatever the woo-woo that was. It has to do with variation in laboratory results. There's a lot of variation, and there's a lot of variation from reading to reading. It can vary by 10 to 20% or more. So if it was 50, it could easily be 55 to 60 as the next time. So that's one of the things that is curing it. The main thing you want to do is slow progression of decline and decrease your risk of dying of atherosclerotic cardiovascular disease.
perfect.
Now Christina, if it had, put it back up.
Yeah, Christine, hers went from 29 in 2020 to 69 now.
Yeah. So my question would be, what was the situation in 2020? Was there an acute renal failure? And my guess is there was. And I don't know how quickly it went from, let's say, 30 up to wherever it went. And the fact is, when you have a 29 GFR, let's just say for argument's sake, if you've got kidney disease, I'm going to biopsy the kidney. If I biopsy the kidney, you'd see extreme destruction of the major components of the kidney called the glomeruli. If it was going to be 29 and stay 29, that's what you would have. You would have
Mm-hmm.
objective evidence that the kidney had massive destruction. My guess is if they biopsied you when it was 29, there wasn't going to be much destruction. It was another AKI that recovered. That'd be my guess. Couldn't tell you 100%.
Oh, here's a good question. Karen, who is one of our earlier questions, she's on spirolactone, which is one of the drugs I take. Also on another one, she's on two of my like 6 or 8 blood pressure medications I take. And she's saying, should she change, that's a key word, to an ACE or ARB?
Yeah, beta blockers, metoprolol is a beta blocker. Beta blockers are not first-line drugs. Listen to the Dadvice on the best drugs for blood pressure. Really good discussion we had. ACE or ARB, anybody out there, unless you have a good reason not to be on it, you should be on it, not just for your kidneys, because it may slow the decline of kidney function, but it also will help your heart. Beta blockers are good if you've had a heart attack. Beta blockers are good if you have something called atrial fibrillation and you want to slow down your heart rate. Not a first choice drug for the rest of you folks out there. You should be on it. At the base would be a max dose you tolerate of an ACE or an ARB.
And then you add your other drugs on
You can
top of
add it
that.
if you're uncontrolled. Yeah, if you're uncontrolled.
Yeah.
Yeah.
All righty. Wow. Okay, we've only got a little over 10 minutes left, so I'm going to scroll to the bottom and see how many of these we can get. Can exercise lower your eGFR? We have a couple people asking about exercising, its impact on CKD.
If you do not keep up with your hydration, as James is doing right now, dehydration is probably the number one cause, in conjunction with a medicine like an NSAID, of a decline in GFR. Stay hydrated. You can get a decline in GFR with exercise if you don't stay hydrated. If you do extreme exercise, you can get muscle breakdown. You run marathons or triathlons, you can get muscle breakdown. And that's why they take these protein powder and stuff to try to prevent that. Or maybe even this stuff called creatine, which I'm not going to get into. But if you are extreme, you can get muscle breakdown, which can cause kidney failure. It's called rhabdomyolysis. It's a long name. So that's the only situation that's really worrisome.
All right. Stacy asked about PTH. Is that related to high calcium in labs? She has high calcium in her last 2 labs, and her eGFR is 55 with no protein. Normal. It sounds like the rest of her labs are normal.
Yeah. Well, again, the PTH, calcium, vitamin D is a very complicated story. So if you have a high calcium, that's concerning. And there's a lot of reasons for high calcium. Generally speaking, people with progressive kidney disease do not get high calcium. The likelihood is that there's something else going on, and you may need a workup for high calcium. You need at least a vitamin D level, and you need to know if you're taking vitamin D. If you're taking vitamin D and you're taking calcium, that's going to raise your calcium. So we need to know your calcium level, your vitamin D level, and your medicines that you're taking. And you may need a workup for other causes of high calcium, especially if you have early CKD.
All right. Okay, scroll to the bottom. Hugh. I think Hugh has a prank name. I'm not going to say it because it looks like
Yeah.
something I would have heard on the Howard Stern show.
Yeah.
But he's saying,
Got it.
hey, Dr. Rowan James, longtime fan. I'm a 38 male, GFR of 8, not on dialysis, getting a PD catheter installed April 3rd. Will I have fluid and or dietary restrictions? So he's kind of asking for some insight on what he may expect.
Well, I'll tell you, that peritoneal dialysis is my favorite form of home dialysis. You can do hemodialysis, where they stick needles into your arm or your neck and take the blood and put it through a kidney machine, or you can use your own peritoneum, called peritoneal dialysis. And your restriction will not be quite the same on peritoneal dialysis, and you can adjust how much fluid you take off with that kind of procedure. And, and the other thing I like about peritoneal dialysis is that it tends to be more gentle to your kidneys. So you've got residual kidney function, GFR of 8. You probably make some urine, which is great. And you want to keep that residual kidney function as long as possible. And the peritoneal dialysis will do that. So I would not be too aggressive of taking off fluid. I would want to preserve your residual kidney function, and that would be my main goal.
All righty. Let me see something. All right. Here's one. CKD 3A since 2008. How do I get my kidney doc to let me take an SGLT2 for 2 months pre-diabetic in the past? Proteinuria. No more proteinuria now that they're following a plant-based diet. So what's your advice for getting a doctor, and I'm going to hope insurance to pay for an SGLT2?
No, unless you're diabetic and you don't have protein in the urine, I don't think you have a case. And you've got you really have kidney disease that's not kidney disease, since you've had it since 08, and 3A may or may not really be kidney disease. I'm going to answer a couple questions real quick.
Okay. Yep.
There's a couple here that says, is there a cutoff for transplant list? Generally speaking, you can get a transplant if you've got a donor and you're older. And I've known people in their 70s that got kidney transplants. I personally think there's some ethical issues about having somebody donate a kidney to someone at that age, but there's not necessarily a cutoff. In terms of getting on the transplant wait list for a cadaver, that will depend upon the transplant center. Deb and Terry, how do you cure anemia? Well, there are great things for anemia treatment. It's one of the most important things that happen with CKD. Your blood count goes down, your hemoglobin goes down. The most important things that you need to do is make sure your doctor checks your iron. Make sure you got enough iron. You may need to take some iron. They can give it to you by mouth or intravenously. And if you're less than 11, you may need to be on that Procrit, maybe once a month. Great treatment, great cure for the anemia. It really has revolutionized treating kidney patients. I used to see people with hemoglobins of 4, 5, and 6. Which is very low, and it's amazing. And they were feeling really bad. So that you can easily take care of. You got another one that I hadn't seen, James?
Let's see. There's a lot to scroll through.
Well, here's one. It's my GFR. No blood flow to one kidney. 43 GFR. Can't do an angiogram. All right. Well, yeah, I get it. And you only need one kidney. And the question is why the other kidney is not showing any blood flow. Is there a clot in it? And that may or may not need to be surgically addressed. There are non-contrast studies called ultrasound, and you can do radionuclide, radioisotope studies. So there are other things that your doctor can do.
How can you lower uric acid levels? This is something I just had to do.
Yeah, well, uric acid is really an area that we don't have a lot of good information. It's the main situation for uric acid is if you have gout, and gout's a really nasty disease that's treated. You treat your uric acid for gout with allopurinol or colchicine, but otherwise, uric acid in and of itself may be a risk factor of cardiovascular disease. But there's no good information about when to treat an elevated uric acid if you don't have gout. And GFR 80 to 110, no meat doing protein. Okay, body. I don't see any significant thing. Yeah, someone's saying don't take calcium. Stacy, yeah, you got to be careful with calcium and vitamin D, because if your calcium level gets up too high, guess what? It can affect your kidneys. It can decrease your kidney function. You don't want to have a high calcium if you can avoid it. We covered it? Okay.
I think we got a good chunk of these.
Good.
Let's see if anything new is coming in at the bottom. Could CKD cause your feet to be hot?
You can with swelling you can get
Ooh.
hot feet if you retain fluid, but beyond that, no. Yeah, so somebody's talking about remaining kidney function be used more efficiently. Both your kidneys are working unless one's closed off, like that other question where there was no blood flow to the kidney.
Mm-hmm.
They both work equally hard. Not blood. You're getting equal participation by your two kidneys, and I think we got it. James.
I think we're.
Can HRT improve kidney function? You know, like I told James, I'm dealing with male and female hormone replacement therapy, and it's an interesting topic. Nothing to do with kidneys, but the bottom line is that we're not using hormone replacement therapy because the scare of breast cancer, but we've changed it, and now it's being used to decrease the horrible symptoms of menopause.
All right, we just got one I really like. This is an easy one. GFR of 74 for person 45. Okay. Any concern?
Yeah, I mean it's probably borderline elevated, and I would just follow it. Nothing to worry about. Again, as long as there's no protein in the urine, that's the main thing. That's the main thing. Yeah. All right.
Here's one that came in near the bottom. Sherry is I don't know what this is. A systemebe scan safe for someone with CKD.
Sesame, yeah, I think it's a nuclear scan. Yeah, the radioisotopes are not. If that's what I think it is, it's a nuclear radioisotope. So I think that those are fine for people. It's not contrast, which could be dangerous, especially if you're diabetic.
Right. We have time for one more if you see one you like.
Someone before COVID had high blood pressure, type 2 diabetes, 59, and did weight 365 at 6'6", and now weighs two. Okay, well, that's great, 295. So that's all good.
Yeah, there's a little more to that. He posted earlier. He was put on dialysis. Now he's stage 3 CKD and no dialysis required. So it sounds like he had an AKI with COVID. Yes.
We had a lot of people that went on dialysis. That was fascinating with COVID. Good for you. Good for you. Now, now kidney function is 40. GFR is 40. Yeah.
Yep.
Well, like we've been talking about, you need to take care of all the risk factors, plant-based diet, get your LDL down, get your gold blood pressure to 120, follow your urine protein, and hope your kidneys stay good. Congratulations.
All right. Very, very good. Hey, we got it. We're at the top of the hour here. We answered so many questions today. This was fantastic. I'm going to bring the doc back up here all by himself on the screen because I want to mention his book. And if you scan that QR code up there in the corner, it will take you to Amazon where you could purchase a copy of his book if you were thinking, hey, you know what? This is great information. I'd love to get a copy of his book, and I'm going to bring the title back up here. It's Learn the Facts About Kidney Disease. Super easy to understand, easy to read. It's written for us, the kidney patients. A lot of times, I've ordered a bunch of books. They're written by doctors, I think 4 doctors. It's like, I didn't go to medical school. I don't know what all these words mean. But it is a fantastic book. And Dr. Rowe and his wife are getting ready to take a global vacation. And he's going to try to find some time for next month. Should be back here next month to talk about another great topic and answer more of your guys' questions. And I appreciate everyone out there. Please give the video a thumbs up, share it, post a comment. That helps YouTube recommend this for other people so they don't find that woo-woo, because there's so much of it out there. And we're kidney patients. Things in the world are so expensive as it is. We don't need to be wasting money, potentially hurting our kidneys on woo-woo. We need to face or be focused on things that actually help, science-based stuff from real professionals in the kidney industry. All right. Thank you so much, Doc. Thank you all the rest of you. Now, I'll be back here Friday. I have another video Friday, a new doctor. He's going to be talking about it's a heart kidney connection. Might be something you'd be interested in. And I'll send you maybe a transcript, Dr. Rowe, so in case you get bored while you're traveling the world. And like, I need something to read.
Okay.
And he'll be here on Friday. And I encourage all of you to join back for that. Otherwise, have a great, wonderful evening. And I'll see you all in the next video. Bye, everyone.